So hello everyone. Again, my name is Gustavo Saposnik. I'm the editor-in-chief of the World Stroke Academy for the World Stroke Organization. And today, we would like to introduce Dr. Chris Anderson, and we are going to talk about genetics and stroke. So thank you for your willingness to participate in this, Christopher, and if you can introduce yourself.
Thank you very much, Gustavo. So yes, my name is Chris Anderson. I am the Chief of Stroke and Cerebrovascular Diseases at Brigham and Women's Hospital. I'm an Associate Professor of Neurology at Harvard Medical School, and I'm an Associate Faculty Member of the Broad Institute of MIT and Harvard, where I study population genetics of cardiovascular disease and stroke.
Excellent, thank you. And we share some similarities when my stay there at in Boston. So anyway, so in your article published in International Journal of Stroke, there was also a brief editorial. So you mentioned, or you describe about the genetic susceptibility of COVID and large vessel occlusion. So you apply a risk score. Can you tell us in simple words for people who may not be an expert in the field, what is a polygenic risk score?
Sure. So polygenic risk is really a way of adding together the individual contributions of many, many genetic variants across the whole genome in association with a trait. So in this case, early on in the pandemic, a very rapid mobilization occurred of genetic scientists interested in understanding why some people get COVID and why some people get such terrible versions of COVID. And so they put together a publicly available database of a variety of COVID-related phenotypes or traits. And the one that we studied was just COVID-19 susceptibility. So people who get COVID versus people who do not get COVID. And so what the comparison is they take over 1 million variants across the genome per se. They look at each variant and say, is this variant associated, is it more common in people who have COVID or more common in people who don't have COVID? And the magnitude of that association is quantified as a beta coefficient or an odds ratio. And then they move on to the next variant. So you have 1 million of those associations. And based on the number of individuals, you have a p-value that's associated with that. And so between those two pieces of information, the beta and the p-value, you can construct something called a polygenic risk score that adds together all those variants. And it sort of collapses all that genetic information down to a single value per individual that really represents the genetic liability to COVID from that score. And so then you can take that piece of information and apply it in different populations. And that's what we did in this study.
So thank you, very, very clear and very informative. So how do you see that genetic can inform stroke clinicians about risks and outcomes?
So, I think in general, genetics and stroke is, I'd say, a little bit lagging behind some other traits like cardiovascular disease, atrial fibrillation. Those are very high-profile examples where, there are genome-wide association studies, including hundreds of thousands of people, if not even 1 million people, comparing people with, let's say, atrial fibrillation and those who do not get atrial fibrillation. And so the amount of individuals and the amount of power you have for discovery is very, very high. And so you can use that to look at, individual genes that contribute to risk, but you could also create very powerful genetic instruments to sort of apply potentially in clinical populations to say, is this person likely to get atrial fibrillation in their lifetime? In stroke, because it's a very common disease, but it's a disease of subtypes, right? And so there's ischemic versus hemorrhagic stroke. Even within ischemic stroke, you think about the Toast algorithm, there are many subtypes within there. So even if you're looking at stroke, you really want to look at the subtypes because that's where the pathology sort of manifests, right? And so we have limited power there. And so the best way to, at least to date in stroke, the best way to use genetic risk scores is to do what we sort of have done here and sort of extract data about polygenic risk from related traits that you want to investigate in stroke, and then apply them in the stroke sample to determine whether or not there's an overlap between the genetic contributions.
Thank you. No, that's great. So what's your vision about the evolving field of genetics and pharmacogenomics in the near future? When I said near future, if 5 years or even more long term?
Great question. I think that I'm going to break that into two pieces, because I think polygenic risk scoring is coming towards clinical populations, kind of whether we not like it or not. The amount of information at Ancestry.com and 23andMe now eclipses what we have in the NIH's dbGaP, right? So many people are going out into the community and sort of getting genetic tests done. And so it's going to come towards us either way. And I think as they've seen, it's shown in Amit Kara and others in Nature paper of cardiovascular disease, we're reaching the point now where polygenic risk scores are starting to make sense to apply to young individuals who have a strong family history, for instance, of cardiovascular disease, and can pick out the top 8% of risk that's 6 times higher than the general population. And many of those individuals, it's not tagging the same things that we typically, they don't have super high LDLs, they don't have CRPs that are 20. They are relatively healthy looking people, but they carry this excess genetic risk. And so I think on the genetic side, that's going to be getting towards clinical populations fairly soon. And we've already seen that, for CHA2DS2-VASc scores, for instance, you can improve the CHA2DS2-VASc score by putting people into a tertile of genetic risk and adding that on as like the CHA2DS2-VASc plus genetics, right? And I think we're going to see more and more people using that for sort of risk stratification and decision making in the clinic. On the pharmacogenomics side, I think we're in a similar situation where people can get point of care testing and outside of a clinical trial, right? And so we saw in the Taylor PCI trial, which looked at cardiovascular endpoints in individuals who were genotyped before being put on clopidogrel, right? Really beautiful trial. And unfortunately, the p-value was 0.06 at the end. So it could not establish that genetic testing before starting clopidogrel and then deciding to put them on ticagrelor, or if they were genetically resistant to clopidogrel, they couldn't show that was very strongly significant. But if you look at the 3-month outcomes, it was very strongly supportive of, and that's obviously in the 3 months is the highest thrombosis risk in those individuals. So I think we're going to see us moving towards that style of pharmacogenomic analysis. I don't think we're quite ready for polygenic pharmacogenomics, but I think for some isolated cases like clopidogrel, which has it's a prodrug, it's metabolized through the CYP 450 enzyme system. Those types of drugs really are amenable to genetic testing at a single variant, right? So it's not even that expensive to do. So I think we're going to see us moving as a field towards incorporating decision points like that into clinical care.
So you mentioned about the CHA2DS2-VASc score, and I was wondering if I can pick up also your brain about how genetics can inform us or help us to decide or implement a specific therapy based on stroke subtypes or stroke mechanism. For example, even big groups, lacunar versus non-lacunar, or the myogenic hypothesis versus, so relating with the relationship between cardiac source of embolism versus non-cardiac sources or cardiogenic stroke.
That's a great question. Also, I think it's a complicated answer. I think CHA2DS2-VASc is a very well validated score, and it's important that if you're going to add genetics to something like that it doesn't contribute information that you're already getting from all of the other things that are getting you points along the CHA2DS2-VASc. And so we have seen that in some cases. So in the case of atrial fibrillation, there are sort of biological processes that are tagged by these genetic scores for channelopathies and things like even titin, which is a myogenic compound, that they are really very orthogonal to what's kind of already in the clinical score. And so when you add the genetics, you get a lift. It's not it's not 20% more powerful, but it's like adding another point to it, right? So I think there's a lot of value there. And I think in sort of helping to unpack what ESUS represents, or cryptogenic stroke as an entity, ESUS has become sort of almost pathognomically attached to the atrial cardiopathy sort of concept. But we made that logical leap ourselves, and in many cases it's not borne out very well as yet, at least. And we recently actually led a separate effort where we looked at the genetic profiles of individuals with stroke of undetermined etiology. and then looked to see if the other stroke subtypes had a genetic signature within there. And what we found was, yes, so yes, cardioembolic stroke signal is enhanced in cardioembolic stroke patients. And if you look at stroke of undetermined etiology, yes, there is a cardioembolic signature in there. So some of those patients have undiagnosed cardioembolic processes. But we saw a very strong signal also for carotid intimomedial thickness. And so when you think about what we are conceptualizing stroke of undetermined etiology, yes, there probably is some ill-defined concept of atrial cardiopathy that is manifesting in some of those patients. But I think there's there's also an iceberg in there of individuals who have sort of subthreshold carotid disease, where they're 50% stenosis, but maybe it's ulcerated. Maybe we don't have the imaging characteristics understood well enough yet to know which of those patients are actually embolizing from their carotids and causing these ESIS type events, right? And so I think it doesn't give us an answer, but it definitely points us in the direction of we need to keep investigating this further and be kind of agnostic a bit to what we think is really going on here. And it may suggest a reason why things like DOACs and ESIS have not been particularly effective, because they're not addressing the actual underlying pathology.
So this is a great example, Chris, and we haven't even prepared this. This is an spontaneous open discussion. This is a great example actually about how, genetics can inform about even patients with a cryptogenic stroke presumed to be cardiogenic. There could be an atherogenic component that may explain that type of mechanism, which opens a completely different therapeutic arsenal. So this is fascinating.
Well, thank you. Yeah, I think it's preliminary and it's definitely hypothesis generating, but I think it does encourage us as a community to sort of vet out some of these other hypotheses that may be going on in a subset of the population with these very difficult to understand strokes. And we all want to get to the point of being able to provide good secondary risk prophylaxis for our patients, right? And in the cryptogenic stroke population, that's very dissatisfying because we can't find anything. We put them on aspirin and a statin. You hope for the best. And I think we all want to get to the point where we can say, like, here's the next 3 things we're going to do. After we've CT scanned and looked for underlying malignancy and done all those sorts of things come up empty. We need to have more tools to explore. And certainly, if I were the one with a cryptogenic stroke, I'd want to get an answer for where it came from. And as it stands right now, we still can't quite get there. And I think that's a really great area for further investigation.
Thank you, Chris. Very, very illustrative and very helpful. So I'd like to take this opportunity too. This is the first interview that we do, and you are seeing my face, but this is a joint effort with the International Journal of Stroke. So I like to acknowledge Hugo Marcos, the editor of IJS, for giving us this opportunity of a true partnership between the World Stroke Academy, the International Journal of Stroke, under the umbrella of the World Stroke Organization. And on their behalf, we like to thank you very much, Chris, for your great work and for sharing your knowledge with us. Thank you.
Thank you very much for the opportunity to highlight the work that we've been doing.
Thank you.